Ollie, an amazing presentation. Thank you so much. It's really thought-provoking. We've had a few questions from the audience, which I'll ask first, and I've got a few questions for you as well, if we've got some time for that.
Sure.
If anyone else in the audience has questions, please ask them in the Q&A so that we can keep track of them. First question is from David Dilly, talking about angle measurements, and he makes a comment that staging patients based on joint angles is completely irrelevant. And he wonders if you have any comment on a chord which is crossing both the MP and the PIP. He says he finds in his patients they tend to try to maximize their MP extension, which makes their PIP flexion worse, rather than allowing their MP to flex and maybe giving them more PIP movement. What's your thoughts on that?
Yeah, Dave, I agree entirely with that. And it's a common thing. It also shows up with the CMC motion as well, that people will have some tightness, and what they'll do is they'll cup their palm by flexing their small finger CMC joint, and that gives them more distal extension. But if you extend their CMC joint, then it shows that. I don't think we have a good way to measure this. And the problem is that the same amount of shortening across the MCP joint produces a different amount of contracture than shortening across the PIP joint. And because the chords are at different distances from the axis of rotation of the joint. And I just don't think we have a clear measurement of it. The point of going through that was that although we can come up with numbers, the only measurements that really are clear and reproducible are when you flex and put slack in all the other joints and then just measure the absolute contracture of the one joint. But there are plenty of people who have significant contractures that you can straighten one joint or the other joint, just not both of them at the same time. And this doesn't fit neatly into any of our categorization. These are referred to, there are a couple papers on this. Well, there's one conference presentation and there's a paper on it as well, referring to these as dynamic contractures. And it's the same problem as in measuring burn contractures in the palm. They're not joint contractures, they're soft tissue contractures at a distance from the joint.
And certainly I think in clinical trials, we've really gone away from angular measurement as any kind of outcome measurement for the reasons that you describe. And their relation to patient function as well, I think, is not very clear.
Right.
Okay. Next question is from Lisa Lichtenstein. This may be more appropriate after a couple of our free papers, or after one of our free papers at least. Are beta blockers known to trigger Dupuytren's or cause it to be more active or more progressive? And are there any other medications and supplements that are known to make Dupuytren's more progressive? We may be about to hear about some
I'll defer that because this is covered a bit in one of the upcoming papers. In terms of medicines that help or hurt Dupuytren biology, it's not clear. There's some that in theory might. There are some medications that are used in cancer treatment that have been shown to be bad for Dupuytren, that can provoke Dupuytren. Some that are used for melanoma, some for gastric cancer. These are obviously not in wide use. And the short answer is there's nothing that has a dramatic effect. And we'll see some medication and disease activity discussion in one of the following papers. But I have to say the effect size is not large. So you can have something which makes a significant difference, but the difference that it makes is not necessarily a big difference.
Great. James Chan wants to ask a question of both of us. So he's worried about reporting bias in patients with family history. You sort of covered that a bit in your talk. He says, is family history not a risk factor then?
Well, I think family history is a risk factor. We have to separate what the risk is. So all the information that we have on diathesis factors, family history, age of onset, disease locations outside the palm, we know about those because those tend to impact post-procedure expectations. And there's been a kind of a historic idea that you can extrapolate these to what happens to people before they're treated. Houston used to talk about people that had these diathesis risk factors and that you had to operate on those people quickly because they were going to progress more rapidly. But it turns out that's not the case. I think we change Dupuytren when we operate on it, and that's where these diathesis factors really come in. So I think family history and self-reported age of onset do make a difference because there's a lot of data that they predict outcomes of recontracture after a corrective procedure. But I don't think that they're predictive of what happens before.
Yeah, and I think your data showed that pretty convincingly. Elizabeth
surprised.
Laird, yeah, quite. So was I, as someone who studies the genetics of this disease. Elizabeth Laird, who's one of our speakers shortly, would like to know about your biomarker study. Have you thought about DNA methylation arrays for looking at the epigenetic clock, given the correlation with age that you saw?
Yes, that's something that we're planning on looking into. So our epigenetic, we're doing whole genome epigenetic sequencing, and we found over 200 genes with methylation profiles in multiple members of the Dupuytren cohort that are only in the Dupuytren cohort and not in the control cohort. Of these, only 15 are in the list of the 1,200 genes of interest that have been published in the Dupuytren genomic literature. And of these, only 5 have been mentioned in the manuscripts of more than 2 Dupuytren publications. And they're the usual players. There's a couple HLA, some collagen genes, and the EP300, which is a gene regulatory gene. Only 2% of the differentially methylated areas are in our exon areas or protein coding genes. Another 2% are in introns, are in promoter regions, and then less than half are in introns, and a little bit more than half are in intergenic regions. So, and that is kind of what you'd expect, because that's sort of the makeup of DNA in the first place. But we've not yet dug into the promoter regions. That's going to be very interesting. I think we're going to find something there. That's the next step. And it seems that every study that comes out on Dupuytren, rather than validating prior work, brings in new data. And I don't think we've hit peak data in Dupuytren research.
That's good to hear. Do any of those regions correlate with any of the genetic loci that we found in the robust genome-wide association studies at all?
No. So I think there's a big difference between the gene mutations and the epigenetic regulation. And as I said, we're just starting. We haven't really built a regulatory gene network model out of this. That's going to be a bit of work. So it's unfortunately raised more questions than answered.
Okay. Question from a patient. Plantar nodules disappeared with time, while hands have got progressively worse, which argues a little bit against systemic factors and more for local ones. How common is that observation, and can you give us an explanation for it?
That's a pretty common finding, and what happens is the first active stage of Dupuytren, it tends to be nodules, and nodules can go away on their own. They can also slowly change and slowly transform into cords. So it's pretty common for people to start with nodules, and then as the disease progresses, the obvious lumpy areas of nodules go away, but and what you have are cords. But if you were to biopsy those cords, you'd find nodule-like biology inside the cords, and so the cords kind of hide that, and I don't think that relates one way or the other to the systemic aspect of Dupuytren, because what's causing these to happen and what's regulating these, and the suspicion is, as with other fibrotic diseases, it's a host of events, local and circulating. So
yeah, so there's a kind of predisposing milieu, which then the local effects cause it to happen. There's another question from Lisa Lichtenstein, who's Dupuytren's has been triggered by trauma, which a lot of our patients report as well. And she's worried about surgery making it worse. And how do you feel about radiation treatment? I think we can defer the radiation question to our radiation webinar, which is the 4th webinar in the series. So Lisa, please do come along to that. There'll be some good data on that. Do you want to talk about patients whose Dupuytren's has been sort of triggered by trauma? Do they do any better or worse after surgery, or any different?
What we know about this is a collection of anecdotes, and I've done an online self-reported survey of this as well. But the collective information on it is that people who believe that they've had trauma as an inciting factor for their Dupuytren tend to show up a little bit earlier, but they tend to not have disease that progresses. As they're not as likely to go on to need corrective procedure as people who had no known trauma. Hand trauma is a tough thing to categorize because we all injure our hands all the time and then forget about it. And so if nothing happens, you don't say, oh, that trauma did nothing to my Dupuytren. But if something does happen, you immediately be like, our brains connect the dots. So I think it is a factor. I think it's a minor factor that may be statistically significant, but the effect size, how much of a difference it makes, is not great.
Great. We've got 2 more questions, and then I think we'll move on. So one from Paul, slightly tongue-in-cheek: your biomarker search, maybe a search for a needle in a haystack, and which corner of the haystack will you be looking at? I think you've kind of covered that. I think it's going to be quite comprehensive. I'm looking forward to seeing some of the results of that. Lou Geru would like to know about senescence-associated secretory phenotype. Any evidence that contributes to Dupuytren's, given that there are hints that it may do for other fibrotic diseases like IPF?
Yeah, Lou, I would expect us to find a relationship of that sort because it's such a common player in fibrotic diseases. One of the interesting things that we've got in the preliminary work on our small RNA analysis, that we found a highly significant differential expression of 3 RNAs and not quite as significant expression of a dozen more in the Dupuytren cohort compared to the others. And one of the more interesting findings is this mitochondrial gene, mtRNA 2L1, humanin-like, which is significantly downregulated in the Dupuytren cohort. It's involved in apoptosis and in senescence, and that might explain some of the persistence of the myofibroblast phenotype, which is one of the hallmarks of Dupuytren. So I think that's going to be a place to keep looking.
Great. I'm going to close the questions here. There are a few questions still coming in. I don't know whether Charlie would be kind enough to type some responses to that while we're watching the videos.